Today we are fortunate to have Dr. Joanne Borg-Stein with us. I first met Joanne back at a conference in Portland, Maine, many years ago, actually. I mean, many, 6, 7, 8, probably 8 years ago, when the first times I was there, and was impressed right away. Very thoughtful and methodical with ultrasound, and very articulate. Joanne comes to us from Boston and Harvard, where she's the associate professor of PMR, as well as associate chair and chief of sports medicine. She's got her hands in many pots. She has talked on posterior hip a number of times. I remember, Joanne, we asked you to do an ICL with this a few years back at AMSSM meeting. And so we are fortunate today to have Joanne with us. So before we turn it over to Joanne, I'm just going to mention in 2 weeks from now, we have our last ultrasound case conference on a trigger finger. This will be the last faculty to give a presentation. And after that, we're going to start having our sports medicine fellows present cases until the end of the cycle year and the summer, then back to faculty. So with no further ado, I'm going to turn this over to Joanne.
Thank you very much. I will share my screen once you stop yours. Yeah. All right. Okay. Are we good now? Can you guys see my screen? Can folks see the screen and hear me?
Yep, we're good.
Okay. Thank you very much. I appreciate that intro very much, Doug. I remember meeting you. Those were fun days back in Portland. My topic this morning is ultrasound of the posterior hip as part of this case series. I have no disclosures, no relevant disclosures. And I want to thank you all who take time to organize this course for us. This has been a non-traditional year, and we've had to find other ways of doing our usual tasks, such as our outdoor PPEs or snowshoeing with masks with my grandchildren. So I must say I'm a junkie. I've watched, I think, every single case that has been presented so far from the very beginning, and they've been wonderful. I hope I can live up to that. So my goals this morning are to give a little bit of background on posterior hip and ultrasound, case presentation. I'm going to go through my scanning protocol that I've come up with over the years, some anatomy review, and then the ultrasound report. So when I first started getting interested in the posterior hip, or butt, as we would affectionately call it, and I started looking around, what I could find was posterior hamstring and sciatic nerve, even from the best of ultrasound physicians. And over the years, I think with lots of interest and publications, the thoughts about what we can do with the posterior hip have expanded, including piriformis and ischiofemoral space. And this is a nice review here on ultrasound imaging for guided injections in this region. And this will serve as some resources and references for folks as well. However, one must recall that posterior hip ultrasound has its limitations, and body habitus is certainly one of them. If there's a fair amount of adipose and a lot of isoechoic tissue, it's going to be very hard to get a good characterization of the underlying structures. What I'm not going to cover today is what's been beautifully covered in the past, which is the proximal hamstring and the lateral trochanteric region. What I'd like to do is fill in the gap that might occur and to complement what's already been beautifully covered in prior webinars. So again, about 10, maybe 10 plus years ago, I started looking around to see what I could find to help explain and identify some of the causes of pain when athletes come with, I'm going to call it buttock pain, because that's usually what they talk about. So we're going to focus today on what Dr. Falvey has published in the past on the gluteal triangle, or I call this about the posterior hip. So we're going to focus from about here and include that ischiofemoral region and not cover the ischial tuberosity in too much detail today. The other thing is clinically, I think both the non-surgical and surgical world has taken more of an interest in posterior hip pain and buttock pain, and again, included some reviews for your reference if you're interested in this topic. Even the New York Times has gotten interested in buttock pain in athletes, and I always smile when I see this article that appeared about 10 years ago on dead butt syndrome. So to begin our case, we have a 65-year-old right-handed runner with right buttock, posterior thigh pain for 1.5 years. This is a very typical patient for me to see. She thinks it began with an overly aggressive deep tissue massage to the hamstring. It was worse with sitting, driving, running, and fast walking. And she was most comfortable with the hip externally rotated and had no frank neurologic symptoms. She had seen my colleague in the pain medicine division and had prior physical therapy, an L5 selective nerve root block. And on exam, it was clearly clinically a mixed picture with a little bit of pain provocation with slump tests and straight leg raising. She had some hip adductor dominance on unilateral squat. Her intra-articular hip exam was normal. She had some mild weakness in the gluteus medius. She also had some pain provocation with a supine plank test, which targets the proximal hamstring, and had tenderness over the region of the quadratus femoris. And this was the imaging that she came with. I just picked one view. This is L4-5, and you can see hypertrophy of the facet joints. And on this view, in the sagittal view, there's some compression of the nerve root and foramen. She also came with this MRI, which showed a low-grade partial tear of the common hamstring and some edema in the quadratus femoris. You don't appreciate it on these cuts, but there was some mild osteoarthritis and gluteal tendinopathy as well. So I'd like to say this is atypical, but this kind of complicated situation where you're trying to figure out what's going on is common. And that's why I chose this topic for ultrasound to help guide us on the diagnostic and therapeutic evaluation. So when we think about pain in the butt, we think about referred causes, intra and extra articular causes related to the hip, some pelvic etiologies, as well as neurologic causes. And this is to remind us all, studies have been done, and you can document that 70% of folks who have intra-articular hip pathology will have buttock pain, which is way higher than I used to think. We used to think mostly of the groin, so something to keep in mind. In addition, almost 90 to 95% of folks who have documented and provoked SI joint pain will present with pain in the buttock. So here's the meat of it. If we do nothing else today, we're going to just focus on this scanning protocol. And the truth is, I welcome any discussion at the end because I kind of pieced this together from other things. I could not find any one specific posterior hip scanning checklist, so I put this together. And what I did was, to make it a little bit more digestible, I divided it up into part 1 and part 2. And part 1 is going to be the superior margin from the PSIS down to the piriformis. And part 2 will be inferior to that, beginning just below the piriformis and involving more of the deep rotators and posterior hip capsules and ischiofemoral space. And I think this is also helpful clinically, but in no means do I feel like you only can have pathology here when you have pain here, because any of the structures in part 1 can refer pain into the deep gluteal region, thus making it a bit complicated to figure out. So we'll start with the scanning protocol for the posterior hip part 1, which is that superior to the deep gluteal space. And what you'll find in all these images is the correlative surface anatomy to let you know the protocol. Now, there's no reason why you can't start this, in other words, from the inferior to the superior direction. I've developed a protocol where I start superiorly and work inferiorly. I always start by trying to find the spinous, the tip of the spinous process at L5, because that lets me know I'm on the spine and not the sacrum. And that's the correlative anatomy. It's really good to palpate the iliac crest and PSIS, because these are going to be really good landmarks and home base for orienting your ultrasound scanning. So lumbar spine. And the next part of this is moving, sliding essentially from the L5 region and just sliding inferiorly till you come to this region in between the two PSIS areas. And I call this the sort of the lumbar spine to upper sacroiliac slide. And this is what it looks like on scanning. We start here at the spine, and then we go inferiorly just till we hit bilateral sacroiliac region. You can get a hint of the sacral foramina here as well. So what this looks like on scanning view with a curvilinear transducer, you should be able to see the sacrum. This isn't that crystal clear, but if you toggle a bit, you'll see the sacral foramina very clearly. And then this is the PSIS sacrum, and this is where the home of the superior sacroiliac ligaments tends to be. Key point here, if you're going to do any injections in this area, is to know where the sacral foramen is and where the SI ligaments live. Then what I tend to do, so let's go back one slide. We're starting midline here. Depending whether you're interested in the left or right side, you can slide over to the left or to the right, and then slightly inferiorly, and your transducer will end up over the, what I call the U-boat. And that is the actual sacroiliac joint region, which is the inferior 1/2 to 1/3 of that SI sulcus. This is medial, this is lateral, and this is what you're looking for. So again, there's always a little bit of a slide involved. And when you're at this ligamentous point that I showed you earlier, and then you go to the U-boat, it's very, very small distance, maybe a few millimeters. You can almost toggle and get there. So it's important to realize that, otherwise you'll just slide right over the U-boat. And this is what it looks like. Here's the PSIS, and just a simple slide, PSIS, U-boat, or SI joint. If you want to do an injection in this joint, you can come either medial to lateral or lateral to medial. I'd say 95% of the time I go lateral to medial. This is a good picture though, since you can really clearly visualize, probably it's the S4 sacral foramen when you do this. Okay, the next transition as we continue our inferior migration is to both slide inferiorly and to turn your transducer in a orthogonal plane here. And what we're going to do is come down onto the piriformis. And this is critically important. There's nothing much back here that you're going to be able to see other than the piriformis that's important with this angulation. So let's go to the video. We're starting at that U-boat SI. We're skin sliding inferiorly and we're angulating till we just come off of the bone and we see the piriformis muscle. And once you're at the piriformis muscle, again, with this diagonal orientation, this is what it looks like to confirm it. Most folks know this. Oops, sorry. We go. So here's the piriformis, and you will internally and externally rotate the hip to confirm that this is piriformis. Most important is the angle. You can internally and externally rotate the hip with any of the rotators and you'll see movement. So you need to make sure that your transducer supports the thought that you're over the piriformis. Okay. The next thing I just want to mention before we move down to the next area is the reflected head of the rectus. So this kind of reminds me a little bit of some overlap with the lateral hip and Doug's talk. But as this reflected or indirect head comes posteriorly and attaches over the acetabulum, folks can absolutely complain of this sort of deeper posterior posterolateral hip pain. And I have picked up many cases along the years of situations where this is really the culprit. So it's just something to think about in your scanning. And here's a reference on the scanning. The positioning of this, usually I have the person sidelining, but since we're doing posterior hip, I just want to tell you that sometimes you can just slide over. And I love this view of the lateral hip capsule. This is distal, this is proximal, here's the joint. And you can pick up a fair amount of abnormalities and enthesophyte, bone spurs, etc., effusion over the lateral hip, and it can really help you. In addition, as a little bit of a sleeper, a lot of folks come in saying they've had gluteal tendinopathy, or they've even had a PRP injection, or they've told of bursitis, and they don't believe that they have a hip problem. And then when you show them that this pain just a little bit superior is their lateral hip, then they're with you that there may be an intra-articular cause of the pain. Once I'm at this sort of lateral hip capsule, you can see the short axis view of this reflected or indirect head, and then I usually turn on it and optimize the image from there. Some of the ligaments in the posterior hip we're going to go through. The anterior ligaments we certainly can't visualize, but we'll talk about these other ligaments that can be pain generators and associated with sports injury. This is a drawing of that. So the superior sacroiliac ligaments, there are superficial and deep. There's long sacroiliac ligaments, which then basically are a chain with the sacrotuberous ligaments, which then is contiguous with the proximal hamstring. So it is not uncommon to have proximal hamstring injuries that then affect or partially tear the sacrotuberous ligament, and thus you end up with this sort of intractable, perhaps underappreciated buttock pain. To visualize the short sacroiliac ligaments, usually in the transverse plane, here is the ilium or PSIS, here's the sacrum, and you can generally see these ligaments crossing over the top. One example of a patient postpartum who had some sacroiliac pain with running, sometimes you can see these hyperechoic patterns consistent with essentially a sprain. Again, PSIS, sacrum, and ligaments coming across. You can then turn your transducer and focus on the long sacroiliac ligaments, the long posterior sacroiliac ligaments. Not sure how much pathology lives there, but there are certainly sacral nerve roots that come out around there that can be contributing to neuropathic type pain. Let's also not forget about the sacrotuberous ligament. Again, this is all one continuous kinetic chain from the ischial tuberosity to the medial border, sort of that inframedial border of the sacrum. This is a point that I don't use very often, but can be another landmark to finding the SI joints. In the transverse plane, you can come to the sacral cornua. If you are inclined to do ultrasound-guided caudal epidurals, you could do that, but you can also move laterally and slightly superiorly and connect with the U-boat sign of the sacroiliac joint this way as well. Another thing in this area that may not come up as much is the sacrococcygeal joint. Certainly gymnasts are prone to these types of injury, and there's superficial and deeper ligaments and joints in this area as well. This is just, I threw this in as a recent case of someone who had an old sledding injury, and nothing had shown up on any of her imaging that could account for her pain other than perhaps this hyperacute sacrococcygeal angle. But on ultrasound, we were able to see this area of old ligamentous injury, and she did quite well with one local PRP injection to the area. So we're going to move on now to part 2, which is the deep gluteal space. I included this again for your reference because there's a lot of good literature coming out on this. And posteriorly is glute max, anteriorly is mostly the hip capsule, proximal femur, laterally the region of the greater tuberosity, medially the sacrotuberous ligament, and inferiorly the hamstrings. Once we have finished up our piriformis, we then need to change the orientation to a more true axial plane to focus in this deep gluteal external rotator region, as I call it. So just to show you what that looks like, here's the posterior hip capsule, here's the superior humerus. It's right there for you. And again, it's also an excellent teaching tool for our patients who swear this is all their hamstring, and they just don't realize that this can be related to hip issues as well. Then I like to call it, again, we continue a sweep. We've been from the piriformis, we're passing over the superior gemellus, and then we're going to pick up the obturator internus, which has this classic appearance as it passes over the superior margin of the ischial tuberosity. There's no other rotator in this area that has that characteristic, so this helps you identify the obturator internus. So again, a more flat appearance, and now that more rounded appearance, and we pass over it, over the obturator internus. And here's a scan just of the obturator internus coming over the top. Next big landmark, inferior gemellus. I'm not sure how much I can easily identify this and with confidence separate it. So I really tend to slide over that a bit and focus more next on the quadratus femoris, which has this classic quadrilateral type appearance. This is what it looks like when you are coming more inferiorly, and then the change in shape lets you know that you have arrived. So you're starting with these rotators, obturator internus, continue sweeping inferiorly. The shape of the bone changes a bit, and the shape of the muscle changes dramatically. And this is the quadratus femoris. And you're at a point now more inferiorly where you can more clearly see the sciatic nerve as a landmark on top of it. This brings us, we are not, when we do the 1 hour AIUM lecture in March, I'll go into more detail, but this brings us to the region of the ischiofemoral space or ischiofemoral impingement. This can present not only with buttock pain, but some medial thigh or groin pain as well. Ultrasound and MRI findings can show some narrowing of this space, some edema in the quadratus femoris. And there's quite a bit now that's been written in the sports literature as well as the radiology literature. And we're not going to have time to go into the details of it. This is to give you some information, and there'll be more discussion of this in a couple of months. I also wanted to make note that there is a bit of a difference. There are two different spaces here that can be measured. One is in this red line, which is the classic ischiofemoral space, from the lateral cortex of the ischial tuberosity to the lesser trochanter. And then just slightly inferiorly, if you go to the lateral margin of the hamstring to this space, this is called the quadratus femoris space. And in the radiology literature, there are some norms and patient identifying numbers as well, just to give us some idea of what these things might look like and how we can drill down a little bit. And here's a little bit more review on the anatomy if you're interested. Here's one example. Thank you, Dr. Eng, of a narrow ischiofemoral space with lesser trochanter, ischial tuberosity. And watch, I'll show you the next slide. With dynamic movement, the sciatic nerve essentially almost comes up and over and gets subluxed. Now, just to show you, this person was completely asymptomatic. But this is one example of a narrowed ischiofemoral space. And risk factors include certain injuries, lesser trochanteric fractures, hip replacements, and other bone lesions. Treatment can include, of course, physical therapy, guided injections, and surgical treatment, ischioplasty if needed. Also, and last to cover in this region is the sciatic nerve. Can split the piriformis, can go anterior to the piriformis, and then usually lies superficial to the deep rotators, and is most, I think, easily visualized if you find the ischial tuberosity and come just lateral to that. And against the more hypoechoic quadratus femoris is more easily visualized. Here's just some examples of this sciatic nerve lying over the quadratus femoris. This is one that I don't think about very often, but I included because a lot of buttock pain not only radiates distally, but can include sort of that inferior gluteus maximus region, can be very hard to pin down. So just a reminder that sort of circling up and around and more proximal is this inferior cluneal nerve as well, which sits in a tissue plane just anterior to the gluteus maximus and posterior to this proximal hamstring ischial tuberosity region. So getting back to our patient, I was telling Doug and Ryan in the beginning, in our group, for a variety of reasons in Massachusetts, we don't generally bill a full diagnostic ultrasound similar to a radiology report, but rather incorporate it into a sports medicine consultation. So as an example of what my report might look like, certainly reason for referral, history, physical, imaging review. And then I make note of and save some key images for point of care ultrasound. So in this case, you might mention the structures that you reviewed that were normal, but you might not, depends on the clinical scenario. and then the abnormal findings or relevant normal findings that emphasize and help us with this particular case scenario. So mention that the hamstring muscle itself appears normal, confirming we knew from MRI there was proximal hamstring tendinopathy. In our reviews, sciatic nerve was normal in size with no focal swelling or compression. And there was edema of the quadratus femoris. And very importantly, it was this area specifically with sonopalpation that reproduced her symptoms. So my impression was this is a complicated multifactorial situation that may include radicular components, proximal hamstring, as well as quadratus femoris edema. However, based on the ultrasound and the clinical correlation, the choice was to begin with treatment of the quadratus femoris. And she had an ultrasound-guided simple steroid injection into the QF, always taking care to avoid, of course, the sciatic nerve from a lateral to medial approach. And I'm happy to tell you, this was now at least a year or two ago, she actually got all better with this simple approach. And it was extremely helpful for me and my career since she's a family member of the head of our healthcare system. So that was a happy ending. So to conclude today for the posterior hip, certainly some of the take-home points. The etiologies are many, and there's overlapping presentations of referred processes, deep intra-articular processes. The anatomy is certainly doable, but can be a little complicated to begin with. I suggest in your thought process and scanning that you think about more superior and inferior components, part 1 and part 2, which concentrates on the deep gluteal space, and part 1, the superior ligaments and joint. Always, of course, we're going to correlate with clinical exam, MRI, and x-rays. It's not diagnostically helpful for all patients depending on body habitus, but even in large patients, if you have other data such as an MRI, you can usually do guided injections unless someone is extremely large. And with that, I thank you. I was just telling Doug also that last weekend, once my family got vaccinated, it was the first time my grandchildren were in my house for the past year. So I'm happy for that at the moment. And I appreciate very much the opportunity to address everyone today and have a little Q&A at the end here.
Joanne, that was fantastic. Anybody that can take a complex subject like posterior hip pain and break it down like you did and make it, simplify it, is a hero in my mind. I mean, that was just really fantastic. Just a couple of comments, and I have a question for you. So you start off mentioning that, you know, in your experience, hip joint pain can be posterior hip pain, and I've had that same experience with lateral hip pain. So I think that's just a point to emphasize that hip pain, as you mentioned, is not always groin pain, and it's always in the differential diagnosis. And I've had a number of people get greater trochanteric injections who really have hip joint disease, and they do have greater trochanteric pain. Just a second comment, you know, there's not many diagnostic tests that we use to curve probe. So this is one of them. And I find I've been gravitating more towards that because even if a linear array probe is able to see the structures, you know, with your presentation and examples, you just see the big picture much better and bring out the landmarks. I do have one question, and it can be hard to diagnose true piriformis syndrome when there's alterations in the course of the sciatic nerve. Like you, if I'm looking for the sciatic nerve, I tend to go to quadratus femoris and then find it easily there and then trace it back. In your experience, how often are you able to see aberrancies in the sciatic nerve going through the piriformis with ultrasound?
Not very consistently.
Mm-hmm.
Maybe others can. I can't rely on it enough to make it my only test of choice. I usually need to go to MRI and ask them specifically to evaluate the nerve.
Mm-hmm.
I don't know what your experience has been.
Yeah, I would say for me at least, pretty inconsistent in terms of ability to definitively diagnose. I have seen a couple aberrancies where the nerve partially goes through the piriformis, but these are people with really good echogenicity and less of a body habitus. I think, let's see, there was a question, what was the pathology with the quadratus femoris in this case? Was there narrowing of the space or was the muscle itself damaged?
I think in this particular case, she had a normal interval in space, and I think this was just a co-traveler with her hamstring. I can't imagine that a massage done a year and a half ago was a problem, but when she had long strides or walking, she had symptoms. So that's, I think, why she responded so easily and so well to just getting rid of the pain related to that QF. In other folks where there's a really narrow space or other pathology within this space, I think it's a much harder diagnosis to treat. So this was, I think, a simpler case, which is why I chose it, where it's really just a chronic muscle edema, muscle injury, which responded surprisingly well, honestly.
And Joanne, when you diagnose on ultrasound potential ischiofemoral impingement or alterations to the quadratus femoris muscle, do you go to an MR or do you typically will treat off the ultrasound?
Okay, well, this is an ultrasound lecture, but I have to confess, I think MRI is really helpful. So I will absolutely use ultrasound, and I'm usually using ultrasound before I have the MRI when someone is sent to me. And then depending on what I find on the ultrasound, decide if I want to go to the MRI. So you can certainly look at the ischiofemoral space. You can look at the distance. Most importantly, always compare side to side. The sonopalpation, at least in my hands, is critically important to try to identify it. And then also, again, I probably see sometimes a more chronic population, but there's almost always some sort of adjacent pathology in the proximal hamstring, at least in the folks that I see. So trying to tease that out with ultrasound is specifically helpful. In terms of the actual muscle edema in the QF and using that diagnostically, the only hope that I see is when I compare it to the other side. If it's a very slender patient and I can get a really good view of the muscle, I will probably feel confident. But in a lot of folks, there's some adipose tissue overlying it, and the sort of tendency to have a little bit more isoechogenicity in that area, I think makes it hard to be confident that the muscle you're seeing has edema and making that diagnosis without some corroborative MRI. So,
yeah, and I just had a case earlier this week where I suspect ischiofemoral impingement and then went to MR specifically looking for that edema in the muscle. And then just one more question that came in. What percentage of proximal hamstring tendinopathy has visible injury to the sacrotuberous ligament in your experience?
You know, Tony, that's an excellent question. I could answer it for you with a number because I actually published on this years ago with the chief of skeletal radiology at MGH, but I don't remember. We actually looked at all these MRIs of hamstring injuries, and there's a decent percentage where, depending on how many hamstring components are injured, you can have concomitant tear or disruption of the sacrotuberous ligament attachment to the ischial tuberosity. So that's with tears, that's with injury. In terms of chronic hamstring tendinopathy and visible ST ligament, I'd say a small percentage, but a large percentage are tender there. Again, depending on body habitus, it can be sometimes a little tricky diagnostically to be certain that you see abnormality. But if they're super tender there, and if you orient the transducer up towards the inferior sacrum and can find the ligament, I would include that in treatment, even if I don't see an obvious sprain or partial tear.
Thank you, Joanne. So this is going to be an invaluable addition to the archive of the ultrasound case series. Again, to be able to simplify and clearly go through the posterior hip is a real art and challenge. And Joanne, gosh, you make it look simple.
Thanks.
And then she had mentioned she will be also addressing the posterior hip. There's a AIUM webinar series, and she'll be doing this in March, and that will be archived on the AIUM website, where I'm sure she'll have more time and go into more detail. And then finally, I misspoke at the beginning. Our next ultrasound case series is in 1 week and not 2 weeks, because we had moved this one. So we're going to have an ultrasound case series next Friday morning, where we're going to discuss trigger finger. So again, Joanne, thank you very much.
Thank you, guys. It's wonderful to be here. Appreciate it.
Everybody have a good Friday and weekend.